Hello everyone, my name is Péter Kulyassa and I would like to present my fourth progress report, and I would like to thank the Center for Translational Medicine to be able to present at this group's meeting. The title of my PhD thesis will be Functional Morphological Investigation of Complex Coronary Pathologies, Recent Modalities. I'm working at the Department of Cardiology at Semmelweis University, and I have 4 projects, from which 2 are finished and 2 are ongoing, and I will elaborate them in the next minutes. So the first one is RAF, this is a radial artery puncture hemostasis evaluation, which is our multicenter randomized controlled trial, and we aim to publish its protocol first. The background of it is that if clinical evidence of coronary artery disease is present, in most cases, invasive coronary angiography is needed to be performed. The gold standard access site for invasive diagnostics and the minimal invasive therapy is the radial artery because of its low complication rate. And this puncture is performed in huge numbers, though the complication rate is acceptable. Because of the huge numbers, with a little upgrade we could improve patient care a lot. And the novel hemostatic dressings, which were developed in the last years, are promising less complications and shorter compression times, which is for the patient's benefit. So therefore we drafted our protocol in which we investigate the gold standard pneumatic balloon band with 2 novel hemostatic compression devices. One is a ketosane covered, and the other is a potassium ferrate covered device. These make it possible to use shorter compression times with lessening the complication rate. We plan to involve 600 patients, from which we already have 480 at the moment, and so we plan to actually end the study this year. We have the inclusion criteria, which is an all-comer patient population with radial artery approach coronary angiography from right or the left radial artery. And actually we have a primary endpoint, which is a device-oriented complex composite endpoint, which is the composite of excess site bleeding, hematoma formation, radial artery damage, and radial artery occlusion. We also have secondary endpoints like the application time of the compression device. So this is already published in Frontiers in Cardiovascular Medicine. My next project is drug-coated balloon effectivity in the treatment of early and rate drug-eluting stent in-stent restenosis, which is a systematic review and meta-analysis of similar subject, also in the subject of interventional cardiology. Coronary heart disease approximately affects more than 100 million people worldwide. In Hungary, it's actually responsible for more than 35% of deaths. And the most advanced therapy in most of the cases is drug-eluting stent implantation through radial artery access. Though the eluted drug is protecting from in-stent restenosis, is still presenting in 10% of the actual cases. And if the treatment of this developed drug-eluting stent in-stent restenosis as ISR, there is no decision about the optimal strategy. 2 strategies emerge from the available options, which are new layer of drug-eluting stent or drug-coated balloon, or DCB. DCB can be the future direction, and it might be not as effective in early drug-eluting stent in-stent restenosis, which is developing in the next 12 months after the index procedure, then the late ISR, which is developing after the 12 months. So our clinical question was, does the time of this ISR occurring affects the outcomes with DCB treatment? So we had an all-comer post-PCI patient population receiving DCB treatment for DES-ISR. We compared early versus late occurrence, and we investigated major adverse cardiac events containing target lesion revascularization, cardiac death, myocardial infarction, and these separately. And also target lesion thrombosis and target vessel revascularization, late lumen loss. So we performed a systematic search, and after that we had only 4 articles available. So we analyzed these 4 articles, which reflects that these low numbers of the articles represent the importance for further studies. The first outcome is the MACE, the major adverse cardiac events outcome, containing target lesion revascularization, cardiac death, and myocardial infarction. And in this, we found a 1.68 odds ratio, which means that the population presenting with early DES-ISR is prone to 68% more recurrent revascularization after the treatment with DCB than the late ISR group. We had another outcome, which is target lesion revascularization, which had 1.69 odds ratio, which means in this population, the early ISR treated with DCB had 69% bigger chance to further develop binary restenosis. And I would like to add that target lesion revascularization was the main driver of the composite endpoint, and it's the most important one. So the strength of this study is that it is actually the first statistically and clinically significant study and meta-analysis of comparing the late and early drug-eluting stent restenosis treatment with drug-coated balloons. There is a relatively low patient number and event count, but if drug-eluting stent restenosis appears earlier than 12 months after the index procedure, more frequent patient screen is needed for worse outcomes. That's what we concluded from this study. And also more randomized controlled trials would be needed on the subject. This is also published in Frontiers in Cardiovascular Medicine. The third project is OpenISR, which is another randomized controlled trial of ours, which is also multi-center. We would like to publish its protocol. And the background for it, it's actually the same as the previous one. In this case, we actually investigate this problem and try to find the best solutions for the problem. Our clinical question was that does the new generation paclitaxel and sirolimus coated balloons, drug-coated balloons, perform as good as the currently used generational DES? And we had the outcomes of late lumen loss, which is our primary outcome, and secondary is device-oriented complex endpoint, mainly containing clinical endpoints. And our hypothesis is that the novel drug-coated balloon perform as good as the current generation drug-eluting stents. So we drafted our protocol in which we use this late lumen loss, which is a continuous variable, and we fortunately have good evidence on this that bigger than 0.5 millimeter late lumen loss well correlates with clinical endpoints. And this is good because we would be able, like, if we were, as we are doing multi-center trial, still wouldn't be able to do an investigator-initiated trial powered enough to show differences in the clinical endpoints. So late lumen loss helps us acquiring new knowledge on this not very well investigated subject of interventional cardiology. So we plan to involve 150 patients and with the randomization 1 versus 1 versus 1. we have 3 arms and 6 months follow-up after treatment of one of the 3 devices. An OCT, which is optical coherence tomography subgroup, this is 10 or 20% of the cases, and then we assess our outcomes. Also, we are almost ready with its manuscript. We're just waiting for some information from our partners to publish that we may be able to investigate further types of outcomes in this quantitative flow reserve outcome, which would strengthen our evidence and our clinical trial. So my last project in the Translational Medicine Center is another meta-analysis, which is conventional versus facilitated hemostatic dressings after radial artery puncture. The background is the same like the previously presented first study, and we compare patients after radial artery puncture with novel facilitated hemostatic dressings with conventional mechanical compression devices, and we have the same outcomes as I presented in the last one. So we have 10 studies and 4 protocols, which we hope will be published, the studies where we want to publish our meta-analysis. And from the availables, we could extract 2 outcomes. One if those is the puncture site hematoma. More than 3,000 patients' data was extracted, and we didn't find any difference between the conventional versus the facilitated hemostatic devices. And we were able to extract another outcome, which is radial artery occlusion. In this case, we were able to find a significant difference, 30% less risk for the facilitated hemostatic devices than the conventional mechanical compression devices. I would like to mention at this point that this is the first data in the literature which presents significant difference between these devices, which are worldwide used huge numbers. So we consider it an important one and would like to publish it in the next few months. So summarizing the previously said, I have 4 projects which you could see, and I had additional activities too, and I would like to thank you for your attention.
Thank you very much for your presentation. I'm not a cardiologist, of course. Can you jump please to your third project, PECO slide? Because my question is connected to that one, that third project, not that one. Yeah. Okay, so the indication of using a balloon or a dash is the same?
Actually, in drug-eluting stent in-stent restenosis we are talking. So we are after native atherosclerotic disease treatment. We have a stent in the coronary artery. We have recurrent restenosis in the artery, in the stent, between the struts. And then we can decide if we are implanting a new layer of stent or just treat it with drug-coated balloon. Actually, the new studies this year's EuroPCR, they presented that native coronary disease can be treated also with just drug-coated balloons. Just between us, nobody takes the risks yet. Because if it were your mother, would you leave a dissection there with a drug-coated balloon, or would you cover it with a stent? Yeah. But this area is evolving actually, and in the next few years, drug-coated balloon will be, in our opinion, have a key role in treating, or not just drug-eluting stent in-stent restenosis, but also native coronary disease. So yes, you can use both to answer your question.
Okay, that's a new information for me. Okay, thank you.
Sorry, just can you clarify, in your clinical question, you're saying if the new generation technology as good as the currently used third generation, but in the framework, the control is second generation?
Yes, that's miswriting.
Oh, so it's
Excuse
just a
me.
typo?
Yeah, that's a typo.
So which one is it, second generation or
second?
third?
Second, yeah.
Okay, thank you.
I declare a bias. I am a cardiologist, but not interventional. Still, I can ask some questions, I think. Now, maybe firstly an observation. You published 2 times in Frontiers in Cardiovascular Medicine, which is a respected journal, but current impact as of today is 3.6. It's not 5.8 anymore. So you should be more ambitious because you have good things. I'll start then with this 1-1-1 randomization trial about drug-coated balloons and stenting. And your primary endpoint is LLL, so loss of lumen.
Yes, late loss,
Late
lumen loss.
Yeah, okay. That is always attractive because it's very subjective. Do you have like a central adjudication panel or somebody that will take a look of what is measured and tell, okay, this is the result? Or will that be done by investigators?
Yes, actually, this is a very good question. Thank you very much. And we are actually developing a free from our judgment, not biased committee to be able to check what we described as a certain degree of late lumen loss, if they see the same as we, because it's very important, as you said, it can be misinterpreted in cases of using like different projections for coronary angio. We are doing high quality angiographies, so with elevated doses of X-ray and the same projections from the vessels. In all centers we are doing this study. So yes, there is a possible bias which we would like to eliminate, and we will elaborate this in the protocol article.
I think you should do it, and it's a difference between the Q1 and Q3 journal. So your aim for this one should be, I don't know, at least Euro intervention or JACC cardiovascular imaging. A couple of projects you are describing. Do you think, and also for this meta-analysis that you are planning, you have published, yes. Did you adjust for DAPT type, DAPT duration, then single vessel disease, 3 vessel disease, which vessel was stented for lipids, lipid lowering therapy? Because we know that with stenting you open the vessel, you don't cure the disease.
Yes, indeed. You're very right with this. Actually, the number of cases and studies was did not let us to assess and subgroup patients and address these questions, which we also have. There are also questions regarding different molecules used in the different stents, which are also not addressed in current trials. So this is a very complicated and very not well investigated part of cardiology and interventional cardiology specifically. And it would be better to perform more trials in the future that these also could be addressed, these questions.
Now, both randomized trials, they are ongoing.
Yes.
For one, you have 4 out of 600 patients. For the second one, it's also, or is it completed, this one?
The second one is at 80%. 80%, yeah.
Okay. Only in Hungary, or you have international?
In Hungary. Unfortunately, we just did it in Hungary, but actually we have a very diverse patient population. There is a different population here in Budapest and in Szeged and Debrecen, so it's very different. So the heterogeneity of the included population will be quite sufficient, I would say, but we will see.
Any pre-specified analysis planned, like emergency PCI versus elective PCI or thrombocyte count?
At this patient number,
number of punctures.
Yes, we always register all of these data in our database, and there is an ongoing interim analysis in this subject, so it's actually ongoing.
Could you explain the difference between the sirolimus and paclitaxel?
Yeah, so they are both drugs which could be used in the polymer coating of the stents which are implanted, and the novel technologies enabled us to involve also sirolimus and limus drugs, which were in earlier not available to be covered in stents. Actually, there is the current data. There is one trial published. If there is clinical difference in the utilization of sirolimus and paclitaxel and an outcome difference, there was no significant difference in the utilization of them. So there would be also this information we will gather with this study, a new one which could strengthen the evidence regarding this.
Which one has a higher risk for stent thrombosis?
It doesn't really depend on the molecule, in this molecule. It rather depends on the stent strut. So get to the basic, I would like to say that drug-eluting stents, second generation drug-eluting stents, have a very low stent thrombosis risiko. These stents, which can be like less than 3%, I would say. The difference is rather between the healing of the vessel, which is influenced rather by the polymer and the other molecules added to the drugs, which are lessening the in-stent restenosis itself. So it's, and also the stent struts, how big those stent struts are, how big the diameter in micrometer is it. It's actually not very well investigated, because it's very hard to do such power trials with strong clinical endpoints just with like late lumen loss, which we are also investigating. Maybe in the future further meta-analysis can be done to address this question too.
Yeah, thank you. One more question. Do you plan to investigate all those patients who have a bifurcation stenting for ISR?
Bifurcation stenting is a very hot topic always, because it's very complicated, and if patients die during intervention, it's one of the reasons that bifurcation stents are not in line position, or the complexity and the longevity of these interventions have additional risks. So this is very important, and thank you for the question. Actually, this year, EuroPCR was present a KISS trial, its name is KISS, that if you implant one stent and you just do a proximal optimization technique to open for some degree, open the struts for the side branch, then you are okay and you don't have to do anything with the side branch. So mainly bifurcation PCI is going in the direction that left main will be the part of the coronary system where bifurcation stenting will be present. I think left main PCI, as it is somewhere at 20–30% of the cases, it depends on the center how many surgery they are doing actually. It's not well enough big numbers to perform such analysis, just a huge scale multi-center, multi-country international trials. So in bifurcation PCI, I think the restenotic properties are better, because actually the flow is better and the vessel diameter is bigger. And from classic trials, we know that the lesser the diameter of the stent, it's more prone to develop in-stent restenosis. So it's somewhat better than by other like LAD or circumflex or right coronary, but it's still a present problem.